أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والرحمن علم القرآن خلق الإنسان علمه البيان. Like every time, let's start with some good thing. Remember to be persistent because success is not the absence of failure, it is the persistence through failure. Today our topic of discussion is acute myeloid leukemia. Sometimes it is missed because it presents with the non-specific symptoms. It can present with a shortness of breath, headache, fever, weight loss, fatigue, or bone pains. So mostly it is taken initially, it is not diagnosed properly. So let's start with introduction. It's a malignant disease which is characterized by abnormal proliferation of myeloid precursors in bone marrow. There is a classification that is the traditional French American British classification of acute myeloid leukemia, which is as follows. M0 is undifferentiated leukemia, M1 is the myeloblastic without differentiation, M2 is myeloblastic with differentiation, M3 is pro-myelocytic, M4 is myelomonocytic, M4E0 is myelomonocytic with eosinophilia, M5 is monoblastic leukemia, M5A is monoblastic without differentiation, and M5B is monocytic with differentiation. M6 is erythroid leukemia, and M7 is megakaryoblast leukemia. The other classifications such as WHO, which is the domain of oncology, international consensus classification for acute myeloid leukemia, so it's above the PEDS, general PEDS. The presenting complaints, onset can be insidious or chronic. In young children, it can last over 1 to 2 weeks. Parents can bring their child with the complaints of fatigue or pallor or breathlessness. There may be particular hemorrhages due to thrombocytopenia. The parents can bring their child with the complaint of bleeding. They may present with upper respiratory symptoms that are not improving despite treatment. The child can come to you with the history of bleeding gums and ecchymosis. They can also present with hemoptysis, bleeding per rectum, or seizures with intracerebral bleed. So history can be short or long with non-specific symptoms of fever or weight loss. You have to elaborate the presenting complaints. Examination, the child will be sick looking and will be looking pale. Vitals, tachycardia, he will be febrile. Child can be hypotensive or normal blood pressure, and there will be lymphadenopathy. There will be hepatosplenomegaly, the gum will be hypertrophied, and you can find petechiae and bruises, particularly on lower extremities, which can sometimes confuse the person with ITP or HSP. So differential diagnosis can be varied, but you must rule out acute lymphoblastic leukemia, any infection that is suppressing the bone marrow and causing pancytopenia or ITP. So investigations to support a specific investigation to diagnose are CBC with peripheral smear, which will show anemia, thrombocytopenia, and can have low or normal or high TLC. Blast cells can be seen on peripheral smear and schistocytes have DIC. Bone marrow and biopsy for immunophenotyping by flow cytometry, cytogenetics, PT-APT, D-dimers and FDP. M3, which is the most common subtype, can sometimes be associated with DIC. Supportive genetics is available. CT-MRI brain if present with altered state of consciousness, chest X-ray, baseline echo as some medicines used have cardiotoxic effects. LDH, which will be elevated. Uric acid is elevated and can show tumor lysis syndrome. LFTs, RFTs, vitamin B12 or folic acid if needed. Treatment. The child should be under the care of pediatric oncologist. At the supportive treatment, you pass the central venous catheter, airway breathing circulation, RCC transfusion if decreased HB, FFV transfusion if bleeding, platelet transfusion if they are low. Infection prevention and prophylaxis, treatment of hyperuricemia and TLS, growth factors such as GCSF. Specific is the chemotherapy, which includes the induction phase, which consists of idarubicin, daunorubicin, or metozentron, and consolidation therapy, and the stem cell transplantation. Remember, that a general pediatrician, whenever he comes across and diagnosed and or a suspicion of acute myeloid leukemia, they must take the advice of the pediatric hematologist oncologist colleague. Monitoring intake and output, diet, no fresh fruits or vegetables, only cooked food and well cooked meat. The child will be authorized age appropriate but limit depending upon the condition. The child should avoid rush or crowds and contact with people who are having contagious disease. The complications greater than 85% complication rate. The most important and drastic and fatal complication is febrile neutropenia. There can be neutrophilic acrine hidradenitis. This may looks like this. The follow-up requires a long-term follow-up. Patients are monitored for cardiotoxicity, growth, fertility, and secondary concerns as essentials. Prognosis 60 to 70% survival rate, 30 to 40% relapse rate. Favorable prognostic factors: age is greater than 1 year and less than 10 years. Good risk cytogenetics from translocation 8 to 21 and inversion 16. And rapid response to induction chemotherapy. No FLT3 ITD mutation. What are the unfavorable prognostic factors? Monosomy 5 or 7 complex karyotype, FLT3 ITD mutation, poor response to induction therapy, secondary amyloid leukemia, for example, post-chemo or myelodysplastic syndrome. Infants or adolescents greater than 15 years. So these are the some of the worst prognostic factors. Now a slide about the differences between acute myeloid leukemia and chronic myeloid leukemia. In acute there will be easy bruising, shortness of breath, bone pain, whereas in chronic myeloid leukemia there will be weight loss and night sweats. And thank you very much for listening, and this is just to revise you and to make you aware the basic things about the acute myeloid leukemia. You must know this, but you can go beyond this. So I have limited myself to the domain of general pediatricians. So this is my number. You can contact me on WhatsApp and for any guidance or feedback only. And I pray that may Allah be our protector, helper and guide and make us a good person and a good specialist. Allah Hafiz.